We are going to talk about an organ which is present in the abdomen or pelvic region. We call them as pelvic organs, but in true sense it is having a dicey or two-tine of presentation. That's why we call them as abdominopelvic organ, which is we are going to cover the urinary bladder. Now, whenever you are going to talk about urinary bladder, we are going to discuss about this organ in few headings like a definition. That's we are going to make a definition out of it. We are going to talk about the position of it, how this particular organ is positioned in this abdominal pelvic cavity, its relationship with neighbor structures that is present like other viscerals, how it is there. And other than this, we are going to talk about how does this particular organ looks like in terms of shape. So, the organ shape we are going to talk about like a surface, borders, etc., etc. And then we are going to talk about like what keeps this particular urinary bladder in position, like so that it not dropping out or coming out of the abdomen. So, it's kind of like we can call it like factors keeping urinary bladder in position, or in short we call them as supports to keep this particular urinary bladder in positions. And then we are going to talk about the blood supply, nerve supply, how this particular urinary bladder keeps this urine at hold whenever it is required and empties it whenever we wish to. So, this is what we are going to cover, this is what we are going to talk. We have done this particular rectum anal canal in this practical classes. We are not going to, no more going through it. So, we are going to directly ending into this particular content which we are going to talk is like so this is the point which you are going to talk about. So, talking about the definition. So, it is a temporary reserve house for the urine. It is holding the urine for a period of time whenever we find an appropriate time to release that. So, it is a temporary reservoir of the urine which is present in the location is concerned that we are going to talk about position. So, in adult this urinary bladder is positioned in the pelvic cavity. So, whenever you are going to talk about the positions of the urinary bladder, it matters to us. I will explain why. So, in adult the positions of the urinary bladder is in pelvic cavity. So, within this pelvis or bony pelvis or true pelvis, this particular urinary bladder is placed. But it can come out of the pelvis whenever it is distended. So, the positions of the urinary bladder is variable depending on status. So, whenever it is empty of urine, this particular urinary bladder is in pelvic position, and whenever it is holding urine, so when it is distended, it comes out to the lower abdomen, and then we call this organ as abdominopelvic organ, that partly present in the pelvic cavity, partly present in the abdominal organ. None of these things matters clinically. That is what we are going to talk about. So, distended urinary bladder, or if it is empty collapsed urinary bladder, the position matters, and you have to explain and you have to write it the like positions of the urinary bladder. Now, it is adult that we are talking about. Now, whenever you are talking about in case of the children or infants, this urinary bladder is lying in abdomen. So, in case of the infant and the children, if you are doing it or examining a patient, this pelvic, this urinary bladder is present in above this symphysis pubis and present in the abdomen or lower abdomen. So, it is an abdominal organ in case of children and these infants. So, this particular positions of the urinary bladder is a point of concern. We will going to talk about some clinical things related to the urinary bladder, then we will come across why these positions of the urinary bladder with the change matters to us. Then we talk about the shape of the urinary bladder. Now, again, if it is in a distended state or if it is in a collapsed state, we are going to address the shape of the bladder. So, when this urinary bladder is empty, the shape is considered as tetrahedral, and tetrahedral with an apex. So, this particular shape of the urinary bladder is tetrahedral with an apex whenever it is in a collapsed state in normal living individual. the shape of the urinary bladder changes in cadavers. We see in cadavers the shape of the urinary bladder becomes like scaffold or boat-like structure. But in case of this cadavers, we are not going to consider. So we are going to stick the shape of the urinary bladder is tetrahedral with an apex which is present to it. So it is having a kind of tetrahedral structure with an apex there. And having said that, this brings the parts of the urinary bladder. So this part we call them as apex of urinary bladder, which is headed towards this symphysis pubis. Opposite to the apex, we call them as base of the urinary bladder, also known as posterior surface. And in between the apex and this base stretch here, we call them as body. So this body of the urinary bladder, apex of the urinary bladder and the base of the urinary bladder, these are the three entities that we have to know. The fourth entity, the apex coming to meet to the base and forms a third part which is rather important, we call them as neck of urinary bladder. These are the four parts of urinary bladder: apex, base, body and neck. So these are the four parts. Other than this, it has got few surfaces. So you have the surfaces of the urinary bladder, we call them as superior surface, we call them as posterior surface, also known as base, and it has a small shallow inferolateral surface which is related to the lateral hip bones. So inferolateral surface, which are two, right and left, superior surface which is this one, posterior surface which is this one, and inferolateral which is this surface which you are seeing here. So this particular tetrahedral in the apex structure or shape of the urinary bladder gives us these different parts and these particular surfaces of it. So again, we are talking about this urinary bladder. This particular shape is tetrahedral with an apex in collapsed state. It gains another surface when it is distended. This particular surface, we are not noticing it right now, becomes a surface when it becomes distended. So this anterior one, which is submerged by the symphysis pubis, we are not considering this as a surface when it is collapsed. When it is distended, it gains another surface. So we call them as anterior surface or anterior wall, and that matters to us whenever you are intervening this urinary bladder. We will coming to again about this particular anterior surface, which is the important surface to me to understand whenever you are going to deal with the urinary bladder in operative field or clinical examination in medicine, surgery, obstetrics, etc., etc. So having said that these particular parts, four of them and the surfaces out here, we are going to talk about the shape of the, we just like talked about the shape of the urinary bladder. Now other than this particular urinary bladder have the surfaces which had got peritoneal relationship. So out of these particular four surfaces which we just mentioned about, only one surface is peritoneal or covered by peritoneal. So this peritoneal relationship, either the organ may be having peritoneal covering or not having peritoneal covering. We call them as peritoneal surface or non-peritoneal surface. So this bladder, urinary bladder, have got two surfaces. One is peritoneal. So only one surface which is peritoneal, we call them as superior surface. So only one surface of this urinary bladder out of 4 or 5 that we have mentioned is having a peritoneal covering, which call them as superior surface. That means this one, superior surface, is having peritoneal covering. Non-peritoneal surface, rest of them like means posterior plus inferolateral and as well as anterior, whenever this anterior surface becomes there, right? So based on peritoneal relationship, we can divide these surfaces of the urinary bladder into two categories. Only one having a peritoneal covering, superior one or superior surface, rest of them are non-peritoneal. That's it. about this particular peritoneal bladder or peritoneal relationship. Now, coming to this intrigue part of this urinary bladder, we call them as So, we just like mentioned about these different parts, saying over here, this is what we call them as apex of the urinary bladder. Opposite to the apex, we call them as base, also known as posterior surface. Don't forget about it. This region between the apex and the base, we call them as body. When this particular apex meets with this base, makes this region, we call them as neck of the urinary bladder. And this particular urinary bladder, you are seeing cut open, seeing from top, this cavity of the urinary bladder you are looking at. So, this particular urinary bladder that we just mentioned, these are the having different parts. This is superior surface, this surface is disregarded, that this posterior surface we have this present on here, and lateral inferiorly which is present in here, right side, left side, inferior lateral surface that is present. Now, this one we disregarded, that we call them as anterior surface. This surface becomes visible only when this bladder gets distended. Now, coming to this particular relationship of the urinary bladder, that means how this particular bladder is placed inside the abdominopelvic cavity. That means what are the neighbor or surrounding structure related anterior or posterior to it. So, in case of the male subjects and the female subjects, it's different. So, let us take a look at into this. So, anterior to posterior, the relationship of this particular urinary bladder in terms of the male subject, this is the symphysis pubis. And behind the symphysis pubis, we have a dead space. We call them as retropubic space of Reed's. So, this space which is having filled with lymphatics, fats, collective tissues which is present on the side of it. Then we have this urinary bladder which is placed to it. Now, posterior to that, we have this rectum which is present in this region. So, we have this peritoneum which is dropping over here, superior surface, and then it jumping on this particular anterior wall of this rectum from this region and creating a space between this vesicle and rectum. Between this we have this rectovesical pouch and septum which is separating between them. So, this is a relationship of the neighbor structures that this urinary bladder has, anterior to posterior, compared to this male subject to the female subjects. Again, same structures we are going to encounter here. This is the symphysis pubis, then we have the urinary bladder, then we have this posterior to that, you have the uterus and the vagina. Vagina have got two walls. This is anterior wall, this is posterior wall of vagina, and then we have the rectum, anterior wall, posterior wall. So, relationship matters over here. This is symphysis pubis, then we have this space which is occupied by the fatty tissues, then we have this urinary bladder. Posterior to that, we have this particular anterior wall of vagina and this part of this lower part of the uterus, we call them a cervix, which is leaning on it, of course, and then we have this rectum and anal canal which is present on the back side. In between this vesicle or the urinary bladder and the rectum, we have the space or this particular septum, we call them as uterovesical pouch or uterovesical pouch or uterovesical septum. So, which is present in between these particular regions, and then further we have this cross sections of this rectum and anal canal. So, these are the structures that is present in terms of relationship of these contents over there. Now, this particular, having said this particular relationship over there, brings us to these particular points which are the factors which are keeping this urinary bladder in position placed in this particular region. We call them as supports, also call them as supports which are keeping urinary bladder in position. So, this position held over here are contributed by two things. One is known as the ligament structures. So, there are some ligaments that are holding this particular urinary bladder in place. Second thing, we call them as the supports which are holding over here in the pelvic support, we call them as pelvic diaphragm. And third thing is the soft tissue structures, or also known as this particular packing material, we call them as like fibrous fatty supports which are holding this particular urinary bladder in position. So, there are few ligaments which are helping us out. There are kind of like a diaphragm which is giving a platform to be in place, and neighbors relative structures which are present to it, and fibrofatty support structures. That means we have these peritoneal folds which are contributing to it. So, coming to the ligaments, there are few ligaments which are of importance. So, a ligament which is coming from the sides of the urinary bladder moving to this particular lateral walls of the pelvis, we call them as lateral vesical ligament. So, they are present on the sides, that is why you call them as lateral vesical ligaments. So, right and left vesical ligaments are there. Then we have a ligament which is present on front side like a pubis bone to this bladder. We call them as pubovesical ligament. In case of this male subjects, this particular pubovesical ligament, we call them as puboprostatic ligament. They are same. In case of the female, we call them as pubis bone to the vesicle. In case of the male subject, we call them as pubis to prostate. These are the two ligaments which are kind of important to us, where the structures held in positions. Other than this, we have this pelvic diaphragm which is principally formed by the muscle. We call them as levator, ani, which is contributed by few muscles. We have a separate thing, we talk about pelvic diaphragm. We will do it later on if it is not covered yet. Then we have the fibrous fatty coverings which is present to it. That means we have these particular folds of the peritoneum, and as well as we have this particular fatty coverings which are packing these particular things. Along with that, we have these particular organs tightly placed in this male subjects and the female subject to keep this particular organs in place. So, these are called as supports or the factors which are keeping urinary bladder in positions in the pelvis, which are keeping this particular organ in place. Now, this is so far we are talking about, we call them as external features of the urinary bladder. Now, if you cut open the urinary bladder, see inside the cavity of the urinary bladder, we are going to see some features which is present inside to it. So, that particular prominent feature that is present to inside of the urinary bladder, we call them as trigon of urinary bladder, which is of concern to us. So, trigon of UB, that is what we are going to talk. Now, before we move to the trigon, that we have to understand over here, this particular urinary bladder is made of muscles. The muscles which are present on these walls of the urinary bladder, we call them as detrusor. So, this particular detrusor muscle which are present in this urinary bladder, keeping urinary bladder integrity towards its side. Now, if you cut this particular urinary bladder, you are going to see that there are two kinds of tubes that are emptying or coming into urinary bladder. One is coming on the superolateral or posterior side of the superolateral side. This is, we call them as angles of the urinary bladder. This one is coming from above. We call them as ureter, right side, left side. They are having an opening there. So, we call them as ureteric opening within this urinary bladder. This is one of the narrowest part of the urinary bladder. This is two openings on the superior side. There is a third opening which is present on this side. We call them as towards this neck of the urinary bladder. We call them as urethral opening. This urethral opening, we call them as internal urethral orifice. So, these are the three openings there. Governed by these three openings, we can imagine a triangular space. This triangular space which is extending or spanning between these two opening of the ureter above and one opening in this below urethra, we call them as trigon of urinary bladder. So, this trigon of the urinary bladder have got difference in terms of origin or some other factors which is for the histological concern. We will talk about whenever we are talking about the histology of urinary bladder later, but this triangular region we call them as trigon of urinary bladder. So, this triangular space or triangular region, imaginary of course, we call them as trigon of urinary bladder. Now, within this particular trigon of the urinary bladder, we see this close to here, we have an organ placed in the male subject. In the male subject, here we call them as neck of the urinary bladder, and in the neck of the urinary bladder, we see a organ placed here, we call them as prostate gland. So this particular prostate gland sitting on the neck of this particular urinary bladder, which is lying on this particular region, helping or present on this region, making a bump out here. We call this bump, which is created by the prostate gland, as uvula, which is known as tongue. That uvula that is present inside our mouth, which is hanging as a curtain inside the oral cavity, we call them as uvula, which is projected by this particular prostate gland median lobe, which is more prominent, more pronounced in case of the elderly male persons. So these are the features that is present inside this particular urinary bladder cavity. We call them as trigon of the urinary bladder, which is related to it. Other than this, in a male subject, we have some viscera that are related to this particular base of the urinary bladder or posterior surface of the urinary bladder. So this is a male subject that you are seeing here. This is a male subject which is having a neck region as a prostate gland. Now in the posterior side of the male subjects, above this particular prostate gland, urinary bladder, above this particular prostate gland, we have a glandular tissue existing here. We call them as seminal vesicle. We have two such seminal vesicle present in here. We call them as right side and left side seminal vesicle. And along with that, we have this ejaculatory duct coming over here. We call them as vas deferens. So in case of the male subjects, we have the vas deferens and this seminal vesicle, which is present in the base of the posterior burrow. Now, whenever is given this particular organ to identify in this examination, especially in the practical, we ask you to show the base of the urinary bladder. So it is difficult to identify the base of the urinary bladder unless until you know the limits of the urinary bladder. So you have to flip this urinary bladder in case of the male subjects going to the posterior one. Inside the posterior one, you will find this particular opening of the ureteric tube. So between this particular ureteric tube stretched to here, this particular surface, we call them as base or posterior surface of the urinary bladder. So this can be defined. Along with that, base or posterior surface continues above as superior surface, which is going to head towards this point. We call them as apex. Now apex can be identified by these attachments of this ligament. We call them as median umbilical ligament. It's a kind of embryological remnant which is present, which has immense embryological importance, which we will call them as dead tissue or kind of like old tissue or embryonic tissue. We call them as medial umbilical ligament. This particular urinary bladder apex is only can be identified by this particular apex of by this attachment of the median umbilical ligament. If you do not have this ligament existing, it's very hard to identify this urinary bladder apex, because in case of this urinary bladder in the cadavers, the shape tetrahedral is no more there. That's why we have to identify the apex by these attachments of the median umbilical ligament, and then we have the superior surface and posterior surface is denoted by this opening of or attachments of the ureter which is going on above. In case of the male subject, we have two another tubes. We call them as vas deferens along with the seminal vesicle present on the posterior surface of the base. So this base or posterior surface in the male subjects, we find this particular opening of this vas deferens along with this particular seminal vesicle, which is also exam question we ask about. Now coming from this, we are going to move forward to this relationship. We must understand very well in a cross section picture, male subject and female subjects, based on how these organs are there sliced over there. So this pelvis which is having this urinary bladder and this rectum and holding between this rectovesical pouch which is present in here, and uterovesical space which is present in here, and this particular recto-uterine pouch or pouch of Douglas. These are the pelvic cavities that is present in this particular relationship of the urinary bladder. Move on. Now coming to here, we are just talking about these things about. So this is the posterior surface of the male urinary bladder having this prostate gland. On top of prostate gland, we have this particular thing, we call them as seminal vesicle, and two tubes. And two tubes are coming over here. This is very highly confusing whenever we are seeing that as a viscera. We usually keep this thing in mind that urinary bladder receives the ureter which should be there. All of a sudden during examination, if you haven't examined this cadaver specimens, you will see 4 tubes are coming, and we will wonder where from these 4 tubes are coming. So 4 uretary tubes or something like that, we often gets confused over there during examination time. In case of the male subjects, we have 4 tubes present in this posterior surface. 2 tubes, this one is vas deferens, which is coming from the epididymis, going to be a transport media for the semens or the spermatocytes or spermatozoas, which is coming here, merging with the seminal vesicle, which is the gland, fitting together, forms the ejaculatory duct and penetrates the prostate gland and pierces to the urethra. This is what it is coming here. Addition to it is superior side, just like horns, we have the ureter. So this ureter should be placed above, this one should be placed down. So this relationship, how to keep these organs or how to keep this like tubes is important. If you do not understand that, during examination you will get nervous and keep on saying wrong words about identifications of these things. So identifying this prostate gland, seminal vesicle and this vas deferens along with the ureter is crucial in case of the male viscera if it is given to it. Now coming to these particular features that we spoke about surfaces of the bladder, which is having a peritoneal relationship. We said that the bladder surface, one of them is peritoneal, which is superior surface, rest is non-peritoneal. So no other surfaces is there. We have this mentioned 4 surfaces of the urinary bladder: superior, posterior and right and left inferolateral surfaces. The 5th surface comes here, we call them as anterior surface. This anterior surface becomes a surface when the bladder becomes distended. Move on. So this is the normal positions of the urinary bladder. When the urinary bladder is collapsed, we see this urinary bladder largely placed under this symphysis pubis. When it gets distended, this becomes abdominal organ, swells like balloon, moves up to the lower abdomen, then it becomes abdominopelvic organ. Now this abdominopelvic organ can be palpated in the hypogastric region above the symphysis pubis. If you are doing clinical examination, abdominal examination in a female subjects or in male subjects, we have this distended organ like this, we often get confused about it. What this structure is present in here. We sometimes consider that presence of cyst, diagnose it as a cystic structure because it's having blood, having urine inside and soft cystic in nature. We say that আপনার একটা cyst হয়ে গেছে, operation করতে হবে. So this particular thing you have to keep in mind whenever you are examining a male subject or female subject, ask to empty the bladder and then go for examination. In obstetrics, it's a kind of rule. If you forget to do these things, you are kind of like in blues because of you cannot measure or you cannot identify the growth of the fetus inside the uterus if you are not emptying the urinary bladder. But again, having said that, this particular thing which has got clinical importance, you see this surface we didn't consider. Whenever you are considering this tetrahedral shape of the urinary bladder, this is a distended bladder gains another surface. We call this surface as anterior surface. And see, this anterior surface is lying right on anterior abdominal wall. Now, if you have to intervene, get inside the cavity of the urinary bladder, how can you reach there? We can reach the urinary bladder through one way. This is the way we can reach here to the urinary bladder. Through this urethra, we are moving here, passing through this urethra and reaching here. Now, if this bladder is distended, this gives a way we can reach through. We can cut through this anterior abdominal wall, get this particular anterior wall of the abdominal urinary bladder and cut it and get inside. So this procedure we call them as suprapubic cystostomy. That means suprapubic cystostomy. Cysto means bladder. Suprapubic above pubes. So this distended bladder, what we do here, we pass a catheter, block it so that urine is kept inside the bladder. Bladder get distended like this and then we cut this anterior abdominal wall, open this and get inside. We often do that to remove some kind of tumors which is big enough, cannot be taken out from this urethra. Say patient is suffering from tumor in here in this region. It's a big tumor. We cannot take it out through this particular urethral tracts. So we have to get inside here. So if you are getting inside, the easiest way to do so is block this particular outflow of the bladder, make it distended, balloon out and then cut this anterior abdominal wall, cut this anterior wall of the urinary bladder and get inside, do the surgery, come out, suture and let it go. So this procedure we call them as suprapubic cystostomy. This can be only possible because the change of positions of the urinary bladder when it is distended and this anterior wall was not there in consideration, becomes a wall or becomes a surface when it is becoming visible. This is what we talk about internal features of the urinary bladder. So having this particular region we call them as trigon of the urinary bladder. Often the trigon of the urinary bladder comes as an exam short note, which is formed by a triangular region is opening of the urethra and this ureteric opening which is present in here, and this having an embryological different origin which is different than that of rest part of the urinary bladder. Move. This is what we are talking about, these positions of the urethra, positions of the prostate and position of the bladder. So this is a section we call them as coronal sections that we are seeing here in the individual. If patient was in position we call them as lithotomy or child birth position. Then we made a section there and take a section through here. We are seeing from the front side flipping here. So if the patient is lying in front of us with a lithotomy position, we cut it and seeing. This is the view, we call them as lithotomic position view. So this is the cavity of the urinary bladder that you are seeing here. This is the opening that you are seeing here. Exiting through here is internal urethral opening. And fitted in here is the male subject having this gland, we call them as prostate gland. And this particular prostate gland makes a bump along this particular opening of the urethra. You call them as uvula of the bladder. This uvula of the bladder becomes pronounced when this gland becomes very distended or very enlarged. Now this particular opening we call them as internal urethral opening. Then it becomes this male urethra. This part of the urethra we call them as prostatic part of male urethra. Then we call them as bulbar part of the male urethra, penile part, etc., which is going to it. So this cavity of the urinary bladder which is having two openings out here, one here and another here. Surrounding over here we have a layer of the detrusor muscle covering here this opening. What are the functions of the detrusor muscle encircling over here there in this opening around this urethra is that whenever we are voiding, this particular detrusor is contracting. So if this detrusor muscle around this region contracts, it collapses this opening so that the urine is not leaked through the urethra going to the kidney. It is released down. So this is utility of this having this detrusor around this region. We call them as detrusor flap or detrusor muscle flap around the ureteric opening. Second modifications of the detrusor muscle is that around this neck of the urinary bladder we have a encirclement of the detrusor same muscle that creates a sphincter. We call them as internal urethral sphincter. So in case of this particular urethra we have two kinds of sphincter there. So if you consider this length of the ureter like this is the bladder neck, we have an encirclement here around this opening, we call them as internal urethral opening or internal sphincter. And outside we have another muscular sphincter, we call them as external urethral sphincter. So these are the two sphincters that normal human being has, internal urethral sphincter and external urethral sphincters. So this detrusor muscle around this neck region creates a sphincter, we call them as internal urethral sphincter surrounding this internal urethral orifice. So this detrusor muscle makes two kind of flaps which is present in here matters to us. Now this sphincters will be talking soon about the physiology of it. Move forward please. Whenever we are going to talk about the voiding and holding of the urine, this is what we talk about, this uvula. So this opening here we call them as internal urethral opening. This is the neck of the urinary bladder. The prostate gland have got few chambers or we call them as few parts of it. So this part of the prostate gland we call them as median lobe, median by the N. So this median lobe of the prostate gland often enlarges, makes a bump around this internal urethral orifice. This bump which is created by this prostate gland within this mucosal fold, we call them as uvula. which is present in here. Enlarged prostate gland, we call them as uvula, which may be of importance when we are going to talk about the enlarged prostate gland that have got clinical importance. We will talk about it. From here, moving to the blood supply of this particular gland, this particular organ receives blood from this artery, we call them as vesical artery. There are two sets of arteries, superior vesical, inferior vesical. In case of the female subjects, the inferior vesical artery, we call them as vaginal artery. So, there are two arterial sources are there, which is predominantly supplies this. Second thing is the drainage of this gland. So, drainage of this gland comes through the vesical veins. Now, what happens with these vesical veins? When it drains, it makes some kind of difference in terms of the veins of the bladder makes a plexus. We call them as venous plexus. We call them as vesical venous plexus. If it is male subject, this vesical venous plexus joins with the prostatic venous plexus. So, vesical plexus joins with prostatic venous plexus. In case of the female subjects, there is no prostate gland. So, only vesical plexus is there. Now, this particular plexus drains to the blood to the internal iliac vein. Now, this is no dissimilarity or no special thing about it. Now, what special thing about this particular plexus is that in addition to that, it drains to this particular internal iliac veins, which is a systemic veins. This vesicle along with the prostate venous plexus, we call them as vesicoprostatic venous plexus. They have a communication with this vertebral venous plexus. Now, this particular communications or kind of special communication that this particular bladder veins has along with this prostate gland drains to the vertebral veins or drains to the vertebra. Now, what is the special thing about this vein? Do not have any valves in it. So, the valve less venous plexus which is present in here, we call them as Batson's venous plexus or Batson's vessels. Now, if we have increased intra-abdominal pressure during coughing, during micturition, during any loads, if you are carrying, this particular blood from this plexus can seep through this plexus and end up into the vertebral veins. Normally, there is no trouble whatsoever. When it gets trouble? If you have cancers of the prostate gland, if you have cancers to this particular urinary bladder. So, then this particular vertebral venous plexus of Batson's matters. How it matters? The cancer cells from this urinary bladder directly can end up into the vertebra and eventually to the brain, to the CSF system, bypassing the systemic circulation. So, it spreads hell quickly than that of rest of the cancer. So, prostate cancers spreads to the bones, erodes the bones, breaks the bones, reach to the central nervous system quicker than any other tumor that normally happen. Normally, this prostate cancer is hell slow to grow, but it spreads really quick. So, once we diagnose a patient having bladder cancer, prostate cancer, it already have metastatized. That means, it has moved through to different organs. So, it is very difficult to stop that cancers. So, this particular venous channel connections which the bladder has along with the prostate gland in the male subjects, in female subjects only urinary bladder, can spread or propagate the spread of the cancers from the bladder and prostate glands towards this particular bones, where the lumbar bones, hip bones, etc., quickly can reach that particular space and erode that regions and spread quickly. Secondary metastasis happens here. So, this is your exam explain why question. So how these cancers of the prostate or the bladder region spreads quickly to the bones, explain with your anatomical knowledge. Right? So this is what we are expected to decode the problem with it. Coming to the last thing about urinary bladder, about the neural innervation. So this neural innervations of the urinary bladder is the last thing we are going to do. So the bladder is receiving two kinds of innervation. We call them as sympathetic innervation and parasympathetic innervation. Now two things to consider about this particular urinary bladder innervation. We have two kinds of muscles present in this urinary bladder, detrusor and internal urethral sphincter. These are the two key role players in case of the functions of the urinary bladder. Now both of these are innervated by the nerve supply from the sympathetic nerves to it. So we have the sympathetic and we have this parasympathetic supply to both of them at the same time. So this side we have this parasym and this side we have the sympathetic. Now see what sympathetic system does to us. Now sympathetic nerves which is innervated, this detrusor, it relaxes the detrusor muscle. At the same time, it contracts the internal urethral sphincter. Now what happens as a result of that? The sphincter remains tight and the detrusor relaxes. That means the bladder is holding the urine. So the sympathetic nerve is holding urine whenever it is discharging, whenever it is stimulated. Opposite thing happens with this parasympathetic. What happens with the parasympathetic? This particular parasympathetic nerve contracts this detrusor. At the same time, it relaxes this internal urethral sphincter. That means it contracts the bladder, keeps this door open. What happens? It voids. So one thing is helping us to hold the urine, other is helps us to release this urine. So once this particular bladder is filled up with urine, there is a stretching which stimulates the parasympathetic nerve, and this parasympathetic nerve contracts and relaxes this internal urethral sphincter and releasing this urine. The urine is reaching to this urethra. This is known as micturition reflex. Clear? So this is normally happens with this. So when we are born, we had these two reflexes existing to us. Voiding reflex, holding reflex. When this bladder was stretched, parasympathetic stimulation relaxes, goes out. We cannot hold the urine. Now as we have progressed, we were able to hold the urine through toilet training. So what comes here then? We have this brain power coming in here. So this brain executes now with toilet training. Now what this particular brain is doing? Brain is innervating or targeting another thing. We call them as external urethral sphincter. So we have another sphincter, we call them as external urethral sphincter. It's highly muscular sphincter that is present outside this urinary bladder. Now this external urethral sphincter is innervated by a set of nerve, we call them as pudendal nerve. Now this pudendal nerve has a control from the brain. So brain says, oh no, this is not appropriate. You have to finish the class, then you use to bathroom. Hold. And this thing, we achieve that through toilet training. So our brain is saying this is not an appropriate time, let Dr. Chaudhary finish and then release. This is called as higher central control of the urinary bladder. So, sympathetic control, parasympathetic control, higher central control rules out or allows this appropriateness of the release of the urine or not. Get it? So, this is we call them as voiding urine, sympathetic flow, and which is holding and super controlled by the brain. Now, other than this, if the bladder is distended, we feel this pain, visceral pain. It carried through the sympathetic nerves and the parasympathetic nerves. If bladder pain coming from the fundus is coming through the sympathetic nerves, near the neck region, the pain is carried through the parasympathetic nerve, going to the same craniosympathetic trunk and reaching to the brain. So, this pain of stretching of the bladder, if we are holding urine for a long period of time, it is overstretched, we are feeling pain now. That pain sensation is carried through both sympathetic and parasympathetic nerves and delivering to the higher centers that we are overstretched, overdue, cannot do this, run out of the class. Now, you are free to run out.